Charge of the lights. So it's really, this is a special pleasure today for Grand Rounds because we invite back an old friend, colleague, and actually he's an adjunct member of the Department of Medical Oncology here at Yale. So Chris Boshoff, MD, Ph.D., is the Senior Vice President for Early Development, Translational and Immuno-Oncology at Pfizer. And there he directs strategies for early cancer drug development and precision and immuno-oncology. So certainly many of us in this room are interested in this area, so we're happy to have Chris. Also, after this, for trainees, certainly our medical oncology fellows, but any other fellows that want to join us in the room behind, we're going to be doing some cases, and in discussing the cases, we'll be discussing new translational strategies. Chris is the co-chair of the Oncology Research and Development Board, overseeing the early portfolio of cancer drugs across the Pfizer enterprise. He's very well trained. He obtained his Ph.D. from the Institute, well, originally from South Africa, but then he had his Ph.D. from the Institute of Cancer Research in London, and then trained as a medical oncologist at the Royal Marsden and the Royal Free Hospitals in London. The reason many of us know Chris, and you've probably seen him speak in this room, is before joining Pfizer in 2013, he was the director of the University College London Cancer Institute from 2007 to 2013. And of course, we have an alliance, we still do with them. He's published more than 150 papers covering cancer biology, tumor virology, and experimental cancer medicine. And we're really happy he's here today to give us this lecture, to seek new collaborations. But also, it's great to have someone like this as an adjunct faculty member, and he comes each year and he does spend time with the fellows and trainees, which is really very valuable to all of us. So Chris, so happy to have you here today.
Thanks very much, Roy. Thank you. Thank you, Roy. I'm happy to be back. I think the last time I spoke here was 2 years ago, and then I was discussing viruses and cancer and how viruses can cause cancer. So today, very different talk. So I'll give you an overview for all the students here, my 3-slide introduction to cancer, and then an overview of Pfizer's strategies and Pfizer medicines in development for cancer, and then specifically more our strategies for how we're going to do combinations in the future, and specifically also combinations with immunotherapeutics. So this is the first slide I always use from my friend Mike Stratton at the Sanger Center, published a long time ago, but it's still such a sharp way of explaining to everyone that cancer is a genetic disease, that we can track cancer cells back to the fertilized egg, and during all our lives cells divide, so there's an intrinsic mutation process, so our cells will acquire mutations, but most of those mutations in yellow dots here are passenger mutations. They don't drive anything, they don't drive proliferation, but of course there's all the other mutations occurring, including mutations from environmental and lifestyle exposures, including what we eat, our diet, we smoke, we drink. And most of those mutations, again, will be passenger mutations. They won't cause any harm. And then there's the mutations that's actually driver, that drives cell proliferation, early cancer all the way to resistant disease post-therapy. What it also illustrates is actually to develop a tumor for most cancers is usually only between 1 to 20 driver mutations. And in some cases, 5 or 6, and in some tumors like pancreatic cancer is more complex, more intratumoral heterogeneity. The principle here of cancer development is important because also as we develop cancer drugs, we basically treat patients usually in phase 1 clinical trials with very advanced, very complex disease. And when patients progress, we not necessarily, or when the patients don't progress, when their tumors progress on therapy, we don't necessarily retake a biopsy, but that disease post-treatment is often even more complex, even more intratumoral heterogeneity, and potentially also more relevant to immunotherapy, potentially also more new antigens by the time tumors progress on current therapy. The next very simple principle for me is just the evolution of cancer. We all thought in the beginning that cancer progresses and is acquire mutations as it progresses, and it's a linear type of monotypic evolution. We now know that most cancers are in fact polytypic, it's branch-like evolution. So different within a tumor, there's various clones developing, so-called intratumoral heterogeneity, and different metastases could have different dominant mutations or different clones. And that's relevant also for targeted therapies, but also in the future for immunotherapy. And my last slide, and this is a slide I actually used from Charlie Swanton. Well, I've adapted the slide, but he uses trees in one of his reviews for, to explain cancer evolution, that some cancers we can think of as a palm tree. So, for example, ER-positive breast cancer, or for those of you working in lung cancer, will be EGFR-positive lung cancer, where all the initial clones will be driven, or there's oncogene addiction to epidermal growth factor receptor. So you can target the epidermal growth factor receptor to actually deplete many of those clones. And then later, as this tumor evolves, you get other mutations developing. The middle one, an oak tree, more like renal cancer. So example I use here is renal cancer, HIF1 alpha, one of the founding mutations or drivers of renal cancer, driving VEGF, so it's an angiogenic tumor, and it's slightly more complex, for example, than some of these truly oncogenic drivers like EGFR or ALK or ROS-positive lung cancer. And then a bush, and that's probably the best example, will be pancreatic cancer. Very early on, developed very complex clones with with a lot of different mutations, and it's clearly we need a different strategy for that disease than we need for ER-positive breast cancer or for an EGFR-positive lung cancer. So what is our strategy at Pfizer? Targeting both the inherent mutations and the signal transduction pathways that's affected in tumors, so developing medicines, targeted medicines against signal transduction pathways, against those oncogenes that can drive, that tumors can become addicted to, and then also developing now therapies targeting the tumor microenvironment. And of course, many of the therapies within the tumor microenvironment will now be so-called immunotherapies. We've developed a number of platforms that's now being used for the new medicines and for the next generation of cancer medicines, including ADCs, antibody-drug conjugates, where there's a payload or a cytotoxic essentially linked with a linker to a targeted antibody. Bispecific antibodies we have in the clinic. Our bispecific platform is currently a bispecific against CD3 on the one arm, and the other arm targeting a tumor antigen, so bringing CD3 cells in contact with the tumor with the cancer cells, so eliciting essentially an immune response. Vaccines, nanoparticles to deliver drugs, more targeted therapies. CAR T-cell, our CAR T-cell program is slightly different from Kite and Juno and Novartis. They are autologous approaches. Our CAR T-cell program is an allogeneic approach, so it's an off-the-shelf program we're developing with a company called Selectus. And then oncolytic viruses. Our oncolytic virus program is currently still preclinically. Just a quick update on the medicines, the Pfizer medicines that's currently in the public domain. That's in phase 1 in blue, in phase 2 in green, in phase 3 in registration intent studies in purple, and then in orange medicines that's now approved. So as you can see, again, very diverse portfolio with drugs targeting angiogenesis like axitinib and sunitinib, cell cycle, CDK4, CDK6, antibody-drug conjugates. These are targeting ADCs, targeting the first two for AML and ALL, inotuzumab CD22 ALL. PTK7 ADC. PTK7 is an antigen overexpressed on a number of epithelial malignancies. The payload with PTK7 is auristatin, so it's targeting auristatin to the tumor microenvironment. DNA repair, enzalutamide, and anti-androgen therapies. Enzalutamide for prostate cancer, antigen receptor. Talazoparib, a PARP inhibitor. Signal transduction, a number of molecules, and I'll mention one or two of these targeting tumors that either there's oncogene addiction or, for example, gedatolisib, which is a pan-PI3K mTOR inhibitor. And then our immunotherapies, and I'll expand more on those. the important thing for the future of cancer medicine for us is how can we combine? What are rational combinations for us? It's easier for us, as a company like Pfizer, to develop these drugs for our combinations to do them in-house because it is quicker rather than have to negotiate with various centers, with various other biotech and pharmas. It's easier, it's more effective. If you can use your own portfolio to do quick studies, phase 1 studies, go, no-go criteria built into the study to make a decision very early on, either on a PD marker or a biomarker or some translational endpoint, whether this is a rational combination or not. I just want to give you one example of our precision medicine because this is a compound many of you, for everyone working in the lung cancer field, is very aware of this drug called crizotinib, also known as Alcori. Crizotinib, because it's such a nice story in cancer medicine, because crizotinib was developed as a c-MET inhibitor. And then it was discovered that, yes, crizotinib also is off-target, can hit ROS and can hit ALK. And then a Japanese group first described a translocation of lung cancer, an ALK translocation. And then, of course, crizotinib was tested very quickly and found in a phase 1 study that the responses were very significant, with the waterfall plot for ALK on your right side. That's clearly a waterfall plot of tumors responding in a phase 1 study, and that led to registration. That phase 1 study was expanded to a registration for crizotinib and ALK-positive lung cancer. Then more recently, we expanded a cohort of patients with ROS-positive lung cancer, 1% of lung cancer, 1 to 2% ROS-positive. And again, a very nice waterfall plot in the middle, and crizotinib was approved in both Europe and in US for ROS-positive lung cancer. And now we're actually going back to the original indication of crizotinib, because crizotinib happens to work, encouraging data seen with c-MET exon 14 skipping, which is a mutation present in, again, 2-3% of lung cancers. So crizotinib, it's encouraging data there. Now we're looking whether we can expand this drug into another setting. So this will become a true TKI that's used in a precision medicine way in various forms of lung cancer. But what do we know? What happens in ALK-positive lung cancer in patients on crizotinib? With all cancers, because of evolution, there's an outgrowth of resistant mutations. There may be acquisition of some mutations, but probably most of these underlying mutations grow out, mutations that are resistant to crizotinib. So in yellow balls here are the various mutations that's been described in patients where the tumors progressed on crizotinib. So Pfizer designed a macrolide medicine called lorlatinib, specifically designed to crosses the blood-brain barrier, because up to 50% of patients on crizotinib with ALK-positive lung cancer will develop brain metastases. So to cross the blood-brain barrier, but also to overcome all these resistance. So preclinically and now clinically has been shown that lorlatinib is active against these various mutations that's been described in the clinic in patients on crizotinib. There's other compounds that's been developed as well: brigatinib, ceritinib by Novartis, alectinib by Roche, who can also overcome some of these resistance. At least some of the preclinical data, IC50s, and this is in a cell line, a patient-derived cell line of a patient resistant to crizotinib. The IC50s and phosphorylated ALK suggest that 3922 or lorlatinib could be a best-in-class inhibitor for these various resistant mutations. So we currently in the end stages of a registration study for lorlatinib in patients resistant to crizotinib, and we're starting a phase 3 study as well in first-line ALK-positive lung cancer of crizotinib versus lorlatinib, to see if we can not only progressive-free survival can expand, but prevent brain metastases or delay the onset of brain metastases on crizotinib. That was the only example I wanted to give of a precision medicine strategy at Pfizer. I now do want to move on to immunotherapy and specifically combinations. The story for me, for many of you, and immunotherapy may start even earlier with Paul Ehrlich, but Coley, in 1892, worked at the Memorial Hospital in New York, where over a period of 20 to 30 years, he really treated thousands of patients with bacteria to induce infection in patients with cancer. After his initial observation that some patients with cancer with sarcomas, he was a sarcoma surgeon, that some patients with sarcoma, if they develop an infection, their tumor actually got better. Many years later, it was thought it was TNF-alpha, that was the Coley's toxin that he was working on. Of course, it took many years until science recognized that cancer immunotherapy is here to stay, and that this is a new form of therapy that we consider now a new form, although there's a long history of immunotherapy that really can transform cancer care. One of the first papers that actually suggested that one of these checkpoints could really be a treatment for cancer was the CTLA-4 paper from Jim Allison and his group in 1996 in Science. But there's a very important observation why I'm showing this specifically. So CTLA-4 is the tumors clearly treated very well in this mouse model, but all the tumors initially increase in size. And this was shown in various other models with the original CTLA-4s. And of course, we now know, we call it pseudoprogression in the clinic, where there's an infiltration of T lymphocytes, and these tumors actually get often a little bit bigger before they go down, or they're stable disease for quite a while before the tumors decrease in size. And of course, you now know, all now know the story of PD-1, the discovery of PD-1, and Li-Ping Cheng, who's not here today, his role in the discovery of PD-1 and his role in cancer medicine, and then the whole new transformative things that's happened during the last 5 years with introduction of PD-1. So I want to touch upon a few things, because one, for us, I think often, especially in the public's mind as well, these are really transformative medicines that's going to cure cancer, that lead to response rates of 60, 70, 80%. We now know that's not true, that the majority of patients do not respond to single-agent checkpoint inhibitors, and the majority of patients that do respond will eventually have a tumor that will progress or escape suppression by a checkpoint inhibitor. So what is the future? How can we harness the immune system to the best we can and integrate these therapies into standard of care, including TKIs, ADCs, anti-angiogenic therapies, chemotherapy, and radiotherapy. So this is just emphasizing that point, that what's transformative about these therapies is they work in so many different tumor types. But this is on average the responses. Most recently, we had approval for our anti-PD-L1 called avelumab, or now Bavencio, in Merkel cell carcinoma. And actually, Merkel cell carcinoma may be one of the solid tumors where we do see the highest responses. Hodgkin's disease, there's perhaps another reason. There's a specific amplification of PD-L1 and PD-L2 in 9p24.1, which is a locus that's amplified in Hodgkin's disease. So there's perhaps other reasons why Hodgkin's disease responds so well. But that's on average. And we expect very soon approvals in many, many other tumor types, including recently nice data from BMS in HCC, in liver cancer that progresses on sorafenib. Of course, you all know the story with MSI-high colorectal cancer, where responses again are significant and very encouraging. But it was time that it was recognized that unleashing the immune system will lead to autoimmune diseases. And some of these autoimmune diseases can be devastating. Colitis, pneumonitis, and potentially one of the most severe, myocarditis. And the case here in the New York Times of myocarditis, so myocardium, then pink and in purple dots, the lymphocytes infiltrating the heart. Rare side effect, but a devastating side effect that's very difficult to reverse once a patient presents with myocarditis. So recognizing now also that unleashing the immune system will lead, that's the mechanism of action, will lead to could lead to long-term autoimmune diseases as well. So thyroid is a classic example, or even diabetes. And diabetes actually was one of the first descriptions of diabetes was here from this cancer center. So how to manage a whole new class of side effects and still incorporate these drugs in combinations with other drugs that's already being used in the clinic that also have significant or could have significant AEs. This is just at a high level for the medical students again. So many of us think of cancer now as hot tumors and cold tumors. Cold tumors are also called immune deserts, where there's very little lymphocytes in the tumor or immune cells in the tumor. And then the hot tumors, those cancers that are packed full of lymphocytes. So specifically those hot tumors that's PD-L1 positive with a lot of tumor infiltrating lymphocytes that have the best propensity to respond to a checkpoint inhibitor. For cold tumors, what do we do? Can we really get T cells in those tumors? And there's things that can be done for that, for example, with a MEK inhibitor in colorectal cancer. But those T cells coming in, are they actually the right T cells that will recognize tumor-specific antigens? So that's an additional challenge. One of the big interests currently for cold tumors, for example, is oncolytic viruses. Eliciting an immune response, eliciting an infection in a local tumor, and then have an immune response there, and then a bystander effect where these T cells go off and then attack the tumor in the different sites. So local injection of an oncolytic virus at the site of a cold tumor. And there's a lot of efforts, and there's many clinical trials currently exploring various oncolytic viruses to try and achieve that. One curiosity about avelumab. Avelumab is an anti-PD-L1, but it's unengineered, which means it's an IgG1 that does maintain the ability to bind to the Fc gamma receptor. By binding to the Fc gamma receptor, it could potentially elicit ADCC effect. The other anti-PD-L1s, durvalumab from AstraZeneca or MedImmune, and atezolizumab from Roche, are also IgG1 anti-PD-L1s, but they are engineered. They do not bind to the Fc gamma receptor. The reason why they did it, because of this potential that a local ADCC effect can deplete tumor-infiltrating lymphocytes in the tumor microenvironment. So we haven't seen that. A lot of work was done with avelumab at the NCI. Initially, a lot of lymphocytes were looked at, peripheral and more recently in tumors, and we haven't seen that depletion of intratumoral lymphocytes. It's of interest more recently, or in 2015, a paper published by Ravitch on his mouse models, in which he suggests that if you do have an anti-PD-L1 against an IgG1 anti-PD-L1, that you do want it to maintain that ability to bind to the Fc gamma receptor, because in his models at least, this leads to the binding to myeloid-derived suppressor cells. We can actually, by ADCC effect, deplete these infiltrating myeloid cells in the microenvironment. So we'll have to see with time if that is a potential advantage of having such a molecule. We know that if we generate in mouse models, or we use mouse models and take our anti-PD-L1 avelumab and engineer it not to bind to Fc gamma receptor, that is not as effective. So it appears with avelumab, at least, the effect, at least preclinically, is better by being a native molecule, an IgG1, that can bind Fc gamma. As I mentioned, our first approval was in Merkel cell carcinoma. For those of you, this was a rare disease. This is almost a disease that was discovered now because of a drug. And Merkel cell is a very rare skin cancer for those of physicians and medical students working in this clinic and in the melanoma clinic. Very seldom will see Merkel cell. 70 to 80% are associated with the polyoma virus, Merkel polyoma virus, that has a large T antigen. Slightly different than SV40T antigen in terms of abrogation of P53 and PRP, but it does have a T antigen. This tumor responds very well. Usually in patients on Merkel cell with metastatic Merkel cell carcinoma, very aggressive disease. And this tumor responds very well. So these are all second, third line responses. In second line, 56% response. We're currently doing a study in first line metastatic Merkel cell carcinoma. But in fact, the approval from the FDA for avelumab in Merkel cell carcinoma is first line and other lines of therapy. So it's not confined to second or third line. The reason for that, if we look at historical data, so this is chemotherapy in metastatic Merkel cell carcinoma with PFS, as you can see there in red, 21 months, 3 months, 2.1 months, 3 months, 2 months, and obviously not doing well on chemotherapy. 3 different studies that was published, or case series that was published, and these are the data with avelumab. So clearly you have the tail that we now see with immunotherapy. There's a tail of patients that do very well. But look at the PFS. The PFS is still short because we have these patients that still do not do well in the beginning. And we see that with most single-agent checkpoint inhibitors, with most cancer types, bladder cancer, renal cancer, lung cancer. That is a group of patients that fall off very quickly, that progress very rapidly on initial checkpoint. We're starting to understand some of the characteristics of those patients. It could be that these are patients with bulkier disease. It could be that these are patients with more bulkier liver metastases, low albumin, high LDH. And it could just be for patients with bulkier disease or heavy disease that we are asking too much of the immune system in the beginning, and we have to go in and either remove some of these tumor bulks or give chemotherapy or radiotherapy to decrease the tumor bulk and then go in without immunotherapy. But overall, clearly a transformative medicine for patients with metastatic Merkel cell carcinoma. These are some of our drugs currently, or medicines now in development, phase 1, 2, and 3. So we also have an anti-PD-1, which we are developing as potentially as subcutaneous for 4-weekly injection rather than intravenously with licabelimab. We've got molecules, I'll say something about OX40 and 4-1BB as agonists of the immune system. We've got molecules to deplete some of these myeloid-derived suppressor cells or suppress the inhibitory metabolic microenvironment, tryptophan IDO1 mechanism, with an IDO1 inhibitor in the clinic, a Pfizer molecule. We've got an allogeneic CAR T-cell program, and then our vaccine-based immunotherapy program, and our p-cadherin, which is the bispecific CD3 and p-cadherin. Just something on the vaccine. The vaccine, we call it a vaccine-based immunotherapy regimen. It's a chimpanzee adenovirus containing a number of prostate-specific or antigens been identified in prostate cancer, and is given with PD-1 as well as with tremelimumab, the anti-CTLA-4. So it's really a regimen of immunotherapeutic drugs that's combined in this vaccine, and this is currently in phase 1. Just a summary again for the students, this is when we develop drugs, the FDA has got mechanisms to accelerate, to help companies, to help patients to get drugs quicker to the clinic. And some of them is called fast track mechanism, or they provide breakthrough therapy designation. Then you can have acceleration of the review of your filing documents, and priority review that can also review. So if we look at the checkpoint inhibitors now approved and where they are, these have really been different from any other class of cancer drugs before because of and the FDA clearly has recognized this. So most of these compounds has been through priority reviews and breakthrough therapy designations and fast track. And this is just the field, what has happened, and most recently for us, the approval of avelumab. But this is what has happened since 2011, the first approval of ipilimumab in melanoma, and then followed up with a number of approvals in melanoma, and then the other solid tumors approved as well in various cancers, and you're all familiar with these data. Again, I want to emphasize something I said in the beginning. I'm still concerned that we expect too much from these single-agent checkpoint inhibitors, and the public and some of the funders and some of the foundations and non-profit organizations are really believing that these single-agent drugs are going to be just curing patients. But as you've seen, the majority of patients do not actually benefit from these drugs. So how are we going to deal with that in the future? So these are some of our strategies, and so the strategies we are developing to incorporate checkpoint inhibitors or immunotherapies into standard of care. The first is eliciting of immunogenic cell death, combining with anti-angiogenic therapy, sustaining an immune response, and I'll give a quick example of each, inhibiting an immune suppressive microenvironment, or combining with DNA damage response medicine. So immunogenic cell death, the easiest way preclinically to elicit immunogenic cell death is either with radiotherapy, and radiotherapy has been shown to upregulate PD-L1 to increase T-cell infiltration to get gamma interferon into cells. But it is dose dependent, and it is probably scheduling dependent. So that's important to recognize with radiotherapy. And the other mechanism is, of course, chemotherapy. So some chemotherapeutics has been shown preclinically to elicit immunogenic cell death, a specific form of cell death that will lead to the translocation, for example, of calreticulin and the secretion of ATP, and then T cells will move in to mop up that area where you have this specific form of apoptosis or cell death. Preclinically, anthracyclines has been shown, for example, in various models to elicit so-called immunogenic cell death. Oxaliplatin as well, or that's perhaps slightly more contentious or controversial. Not all chemotherapeutics. Doxil has been shown to do it, and in various preclinical models it's been shown if you combine Doxil with either CTLA-4 or with a PD-L1, you do get increased cell death, and you do get, at least in mouse models, you get increased killing of the tumor. So we have taken this forward. Doxil is used, as you all know, in platinum-resistant or refractory ovarian cancer. So we're testing this hypothesis in a phase 3 study, actually, with avelumab versus Doxil plus avelumab, in a 3-arm study to test both hypothesis, whether avelumab, a checkpoint inhibitor, is better than standard of care in a very difficult to treat population, platinum-resistant or refractory ovarian cancer. Or if you combine it, do you have a significant benefit because of the so-called immunogenic cell death? We did design first a phase 2 randomized study, but by the end, when you look at the numbers you need to see whether it's really significant, you end up with having a registration study. So it's a hypothesis we're testing in this setting. Locally advanced head and neck cancers, where we're specifically testing the combination of cisplatin plus radiotherapy plus a checkpoint inhibitor, to bring a checkpoint inhibitor into the management of locally advanced standard of care head and neck cancer, which is cisplatin radiotherapy. VEGFR, so I'll specifically mention Inlyta, because Inlyta is a Pfizer compound, or Inlyta or axitinib. It blocks VEGFR 1, 2, and 3 very effectively, particularly VEGFR 2, and very active against VEGFR 2. VEGFR 2 has previously been shown to be expressed on dendritic cells. It's been shown to be expressed on T regulatory cells. So potentially, if you block VEGFR2, you can get rid of those suppressive T regulatory cells. The first study we did was actually not with avelumab, was with pembrolizumab and axitinib in first-line renal cancer. And this is, again, encouraging waterfall plot. Each bar is obviously a different tumor from a different patient, with a majority of patients responding to this combination, with a high overall response rate of close to 72 or 70%. On axitinib or Inlyta alone, the response rate is approximately 25 to 30%. Pembrolizumab alone, or Keytruda, in the setting of first-line renal cancers, again 20 to 25%. So it could be that it's at least additive in this setting. And this is a very nice example currently of using a TKI with a checkpoint inhibitor. And here are the spider plots for the duration of therapies. Various companies have started to combine their specific TKI or their favorite TKI molecule with a checkpoint inhibitor. Many of those studies has been stopped because of AEs, specifically interstitial pneumonitis. And sometimes we can go back and then see that TKI actually do elicit a interstitial lung disease by itself, maybe a low percentage, but it's appear if you combine it with a checkpoint inhibitor, you really increase the lung toxicity often for these TKIs. So it's something we'll have to keep an eye on, also with axitinib, obviously. We have an ongoing study now. We will present, and there's an oral presentation at ASCO on avelumab plus axitinib in first-line renal cancer. And there's now 2 phase 3 studies ongoing, Keytruda plus axitinib versus standard of care Sutent, and our study of avelumab plus axitinib plus standard of care Sutent in first-line renal cancer, to really see if we can drive those progressive-free survivals, which used to be with first-line metastatic renal cancer 10, 12, 13 months, can drive it up to 18, 20, or even higher. So really trying to be meaningful difference with this combination. The agonist, so sustaining that immune response, the only one I want to mention is OX40 and 41BB. OX40 and 41BB both express on various T cells. We used to say that OX40 is more for CD4 positive T cells and 41BB more for CD8 positive T cells, a little bit more complex. I won't go into all the nuances there now, but in general it's felt that both 41BB and OX40, when they activate it, can drive memory or maintenance or the survival of CD4 and CD8 positive T cells. And in fact, as you will know, in many of the CAR T cells that's currently in the clinic, the cytoplasmic domain from 41BB is incorporated into those CAR T cells because it essentially blocks apoptosis. It increase the memory, the survival of those CAR T cells. So 4-1BB is incorporated into CAR T cells. So we've got agonistic antibodies for both 4-1BB and OX40. And we've also shown preclinically in-house and in collaborations that 4-1BB works very well, or CD137 with rituximab. Some of this effect could be also by way of ADCC, especially in follicular lymphoma. And again, waterfall plots of patients previously treated that we presented at ASCO in non-Hodgkin's lymphoma, in green follicular lymphoma resistant to rituximab. If you add rituximab plus 4-1BB or CD137, very nice responses. And it appears to be at least an infiltration in some of these tumors of lymphocyte within those tumors. Li-Ping Cheng here at Yale has also done work with 4-1BB and a checkpoint inhibitor to show that in various mouse models it could work. And we've also done in-house work to show that that could be a rational combination. And just in the last one, I'll show you, if you actually in this one deplete the CD4 positive T lymphocytes, you delete some of the effect. It could be because you're actually depleting the T is another one. Yeah, you deplete some of the T regulatory cells if you with CD40. So this is the green. So in green, if you deplete CD4 in this model, you actually increase the efficacy, and presumably it's because T regulatory cells are depleted further by depleting CD4. Okay, so we have shown data with 4-1BB single agent at ASCO last year, and also with 4-1BB and Keytruda, and we're continuing to develop now in phase 2 in checkpoint-naive first-line lung cancer patients, avelumab plus utomilumab, 4-1BB, and also in a triplet that has started now with avelumab, OX40, and 4-1BB. So this is one mechanism to see if we can enhance and sustain the immune responses. So we're not necessarily expecting deeper responses, but knowing the mechanisms of OX40 and 4-1BB, the duration of responses may be longer, maintaining those T cell responses. We also have a diffuse large B cell study where we actually have various combinations of 4-1BB with avelumab and rituximab, and also with azacitidine. And there's a whole reason why azacitidine is now used with immunotherapy, that perhaps we can, if there's questions on that, I can discuss that afterwards. And then with our bendamustine, again, is one of those immunotherapy, one of the chemotherapeutics that has been shown preclinically to elicit an immune response. So this is an important study for us in refractory diffuse large B-cell lymphoma. We'll have a quick signal from the first 3 arms, and then pick the winner, the arm that performs the best, will be taken forward into a registration strategy against standard chemotherapy, and including Arbenda, that is used in refractory or resistant diffuse large B-cell lymphoma. The fourth strategy is combined checkpoint inhibitors with drugs that, with agents or targets of this immunosuppressive microenvironment. And this is a whole talk by itself, but essentially this is, for all of you, this is probably going to be a bit of a coming out for IDEA1 at ASCO this year. So there will be 2 oral presentations, one from BMS and one from Merck Sharp and Dohme on IDEA1 combined with nivolumab or combined with Keytruda. The data that was previously presented in melanoma, it does appear that blocking IDEA1 increased responses. We still don't know if those responses are maintained and if this really going to translate into survival benefit, but there's a great interest in a number of molecules and targets that creates this immunosuppressive metabolic microenvironment, a metabolic microenvironment that's immunosuppressive. So targeting IDEA1 is just one of them. During the next year, and 2 and 3, we're going to hear a lot on the arginase 1, adenosine, and also on CSF1 or MCSF inhibitors. So our current molecules in the clinic in this field is we have IDEA1 that's in phase 1, and we hope to combine with avelumab later this year. And we have an anti-MCSF that's very similar to the anti-CSFR1 that was first developed by Roche, and then Plexicon, and then 5' and a number of companies with their anti-CSFR1s. The MCSF and anti-CSF1 or CSFR1s are there to block the myeloid-derived suppressor cells, the suppressive myeloid cells. And then these others are this metabolic immunosuppressive microenvironment. And I just show you one of our preclinical models in various preclinical models, again suggesting that if you add our anti-MCSF to a checkpoint inhibitor, that you could increase, and with or without 4-1BB, you could increase responses in tumor types perhaps where there are more myeloid cells present. So, for example, this is one of the combinations we are testing in ovarian cancer in a phase 1 study. The last one is using DNA damage, tumors with DNA damage response repair defects, DDR, used to call HDR. So these are tumors we now know that often if they do have a DDR, these are also happens to be tumors that are also have a higher mutational load. So they could be tumors that are hotter, or they could be tumors that have more new antigens that could be recognized by the immune system. We know that, for example, in BRCA positive ovarian cancer, there is an increase in T lymphocytes. There's more TILs within those tumors, and there's actually a correlation that's been published at least once on outcome in the TIL infiltration in these tumors. And we also know that often there's an interferon gamma signature that correlates in tumors with DDR defects and DNA damage response defects. So we are very keen to take forward a large program that will start later this year, combining our PARP inhibitor talazoparib with avelumab in a basket study where we select patients for DDR in various tumor types. In 4 or 5 different tumor types that will be tested in this basket study. Talazoparib, for those of you specifically interested in PARP inhibitors, is slightly different from the other PARP inhibitors, that it has this additional effect that's independent of the catalytic activity, which is so-called PARP trapping, where PARP is trapped actually on single-strand DNA defects, and that could potentially be exploited in combinations with chemotherapy, for example, with talazoparib. And there's a lot of preclinical work that's ongoing by various academic groups in the US to test talazoparib with various combinations to exploit this additional potential activity of talazoparib. And this is just a summary of essentially what I told you today, of the combinations that's either ongoing in the clinic now, that are the straight lines, or the dotted lines are those planned, that will start soon. You would have seen data presented at ESMO with enzalutamide, Xtandi prostate cancer with Keytruda. These are patients who progressed with metastatic prostate cancer on enzalutamide. PSA increased, and then Keytruda was added, and then PSA started to go down again. So there's a number of studies being planned also now with enzalutamide in the setting to see if we can bring immunotherapy into prostate cancer as well. This is just our CAR T cells. This is a picture, electron microscope of monkey adenovirus. That's the basis for our vaccine-based immunotherapy regimen, and then our bispecific that's in the clinic now as well. So thank you very much. Thanks for your attention.